many of you attended one of my talks last year. I've been in Sarasota, maybe that's on your little bio there, since 1993. Joyce and I came to Sarasota, and I started practicing neurology here after doing research at the National Institutes of Health, studying at the Cleveland Clinic, doing research at the University of Rochester, neuroscience studies as an undergrad, and beginning in 1978. Yes, I'm that old. And really, at the heart of what I do for my patients is science. I'm a scientist. I'm a neuroscientist first. And then I became a neurologist. I actually remember when that shift occurred. It was after our second child was born, and I looked at salaries for neuroscientists. But that's okay. That's okay. Which is really a shame, because scientists and researchers in general don't get the recognition. Academicians don't get rewarded in our society, and I won't get into that right now. But certainly we need to do better compensating our teachers and our researchers. And thus I ended up being a clinician. But I still have a researcher's mentality. I still like to read about why things work, and if the studies showing that they work are done in a rigorous manner. And I have embraced cannabis as a medical therapy because I've seen the science. And I'm going to share some of that with you. I hope the science isn't too dense. I apologize in advance if that's the case. But it's hard to get away from the science. That's what I do. So as far as the congregation is concerned, I have to admit, I listened to the Reverend's sermon from last Sunday online, because I thought he was going to be here today, and I wanted to have some ammunition to just joke around with him. But suffice it to say that I think it's pretty cool that those sermons are all online and available for you all to listen to. And I fully encourage you all to listen to the one from last Sunday again. What are you laughing at? Okay, so here I am. I'm practicing neurology. I had learned about the endocannabinoid system after it was discovered in the 1990s. And then when finally it became available for medical use, as a neurologist, I thought that was fantastic, because so many of the conditions I treat are challenging. Patients with ALS, dementia, but also Parkinson's disease, Tourette's, migraine. These are conditions that don't always respond to conventional therapy. Some of those conditions don't respond at all to conventional therapy. And so being able to see the research from around the world and hearing the patient's stories about how cannabis therapy works for those conditions, that's an option I could not pass up as an offer to my patients. Now, cannabis through history has been used for many different medical reasons. And I know that this slide is illegible from where you're sitting, but I just wanted to convey to you the scope of how cannabis as a plant has been used through history, beginning with the earliest evidence back in 4000 BC. Back in here in the Middle Eastern countries, 4000 BC, cannabis was used. We can excavate remains of individuals and ritual objects and see through molecular analysis that THC was being used at that time, not just as a spiritual device, but also as a medication. And then after the 2nd and 3rd centuries BC, it became a popular way to treat patients in the Greek and Roman era, and then in India, and in the late 1800s, William O'Shaughnessy brought cannabis from India to England. That's why we call it indica, because it was cannabis from India. And Queen Elizabeth at the time, with her Dr. Reynolds, used cannabis to help with migraine and menstrual cramps. We have all these records for thousands of years how cannabis was used for different conditions. in the 19th century, it was very important to use cannabis during the cholera epidemic. It was effective in reducing that type of GI illness so that patients survived. It's remarkable that for thousands of years, this plant has been used. Now, in addition to medical and spiritual reasons, it was a cash crop. It was used to make rope. We know that the initial draft of the Declaration of Independence was written on hemp paper, even though the final version was not. We know that sails were made from hemp into cloth so that the explorers could traverse the Atlantic Ocean. So I'll talk a little bit more about this, but the plant, the cannabis plant, is very important, not just as a spiritual or medical resource, but as an agricultural crop, perhaps the oldest agricultural crop that humans found was useful for a variety of reasons. Now, I think since we are in a house of worship, I'll just make a Bible reference quickly. Cannabis, some believe, was mentioned in the Bible in Exodus 30, 22 to 25. And this passage from Exodus here, right here, this passage actually is the passage that's being read in Jewish synagogues this week. Because, as the Bible study continues throughout the year, different passages are read. And sure enough, this particular passage has to do with the creation of the holy anointing oil. And holy oils were comprised of, according to the Bible, myrrh, cinnamon, and then this thing here, Cannabis, cassia, and olive oil. Now this Cannabis, people believe, is cannabis. And the translation here is aromatic cane, Cannabis. And some people believe that's actually cannabis in the Bible. Perhaps that's true. I would have asked your reverend if it was. But we know for sure that also around that time, Greek physicians were documenting cannabis as a useful plant to treat a variety of conditions. And here in this drawing, and with the accompanying text in the Greek documentation of medical therapies, this cannabis plant, here you see the word cannabis right here. This cannabis plant was described as being helpful for pain in the ears. So there you go. I think that's probably headache. Now here's a little bit more of an updated map, and I'm going to share this with you, Alice, if you want this one. This came out in January because Michigan, this past November 2018, Michigan and Utah voted to legalize medical marijuana. Actually, Michigan for adult use and Utah for medical use. And then the other gray states here I won't go into again, but they're the ones for CBD, whereas South Dakota, Kansas, and Nebraska, and Idaho, still no CBD and no THC. I had a patient in the office yesterday who's originally from South Dakota and came into the office with their son, who was a federal trooper. And we're sitting there talking about cannabis therapy, and they asked me, is it okay to take the cannabis across state lines? Now, I didn't know he was a trooper, but he turned out to be a real trooper. So federal regulation is complicated and needs to be addressed in order so that we as a country can move forward with cannabis research. And I think that day is coming. In January, just this past January, there was a new bill proposed in federal government to remove cannabis as a Schedule I drug. So this is a bipartisan bill. The original Schedule I prohibition was enacted as part of the Controlled Substances Act, Nixon, in 1970. Suffice it to say that the trend is towards more and more cannabis therapy being available in a responsible way, and as well as with adult use. And the feeling among most Americans, a full 63% of Americans approve of legal marijuana, compared to 12% in 1969. So that's the trend. Now in Florida, the trend is also quite strong. This graph here shows that between November 2017 and 15 months or so later, January 2019, the number of patients that have registered to use medical marijuana in Florida increases at a rate of about 11,000 new patients per month. In New Jersey, which is, okay, half the size of Florida, there were only 11,000 patients in all of 2017. So we're seeing a significant, widespread adoption of medical marijuana here in Florida. Now, the qualifying medical conditions differ from state to state, but it's interesting to look at what the legislators decided was okay for medical marijuana use here in Florida. Glaucoma is on there, but migraine is not. Tourette's syndrome is not on here, even though we have evidence, and I'll discuss that with you. Parkinson's is on here, but essential tremor, which Katharine Hepburn had, that's not on there, but it helps for essential tremor also. Dementia is not on here, but Parkinson's is. So we also have a designation here that allows medical practitioners like myself to qualify patients to get cannabis, because you need to be qualified. In order to get cannabis therapy, you can't just go to the dispensary and buy cannabis. And I'll talk more about that. But the first thing you have to do is qualify by having a visit with a qualified physician. And one of the categories that you might fall into, if you don't have one of these things, is a medical condition of the same kind or class or comparable to one of those above. So that's kind of a big basket of possibilities. So when I see patients with essential tremor, I put them in the same kind or class as Parkinson's, because they have a tremor, it's just not a Parkinson's tremor. All right? So one of the points I want to make with this slide is if you're thinking that cannabis therapy might be something you would be interested in trying, and you don't have Crohn's or glaucoma or one of these other conditions, that's okay. We can fit you into this category usually if it's appropriate. And for example, if you have degenerative arthritis, you've got pain that won't quit, and you're done taking anti-inflammatories and you don't want to take opiates, cannabis might be a reasonable thing to try. We can fit you into one of these classes, so I'm pretty liberal about that kind of thing, but in a responsible way. So what does it take to start cannabis therapy? What's the process? Well, as I indicated, a qualified doctor like yours truly, which really only means in the eyes of Tallahassee that I'm a licensed physician and that I took the online course. So pretty much any licensed physician that takes the course can qualify patients as a qualified physician. So there's doctors out there that don't really know much neuroscience that are doing this, and that's fine, but I don't think it's great. I review medical records. We perform a brief history and physical in my office after your appointment is made. And then, after lots of education, you wait for the state to approve the application, which takes about 5 days. And then you can go ahead and purchase cannabis at the dispensary. So the whole process takes about a week. If you're interested in trying medical cannabis, you can call our office, set up an appointment to come in. I get you in, we talk about how to use cannabis responsibly, what your condition is, what your experience with cannabis is, how the different formulations work, oral, tinctures, and so forth, and what might be the best way to start therapy. Then we enter the orders into the medical marijuana use registry. And within 5 or 6 days, you can go to the dispensary, get your products, and try your medicine. It's simple. Now, this fellow here, Dr. Schultes from Harvard in 1971, made a trip to Kandahar, Afghanistan, to learn about cannabis plants. And this is a short male plant, and this is a taller female plant. And basically, as Alice said, we use the word cannabis to refer to marijuana, or should I say, marijuana and cannabis may be synonymous in a way. But truly, the way the botanists talk about it, do we have any botanists in the crowd? Budding botanists? Okay, so cannabis is the genus. It's the main category of the plant. And then there's different species that belong to the cannabis genus and species. So you can get cannabis sativa, or cannabis indica, or the short cannabis plant is cannabis ruderalis. And these are designations that the botanists use to describe primarily what the cannabis plants look like, all right? So let's say you had a short, broad-leaf plant or a tall, narrow-leaf plant. That would fit into these different categories based on the appearance of the plant. Now, what we now know is that appearance ain't everything, because different plants have different amounts of THC and CBD, which are the molecules, the cannabinoid molecules, that are so important for the biological effect. So when we as physicians look at cannabis medicine, we don't use the terms indica and sativa so much as we do ratios of CBD to THC and the chemical composition. That's a more accurate and relevant way for us to talk about it. Nonetheless, the phrases indica and sativa are very useful. Now, another type of cannabis plant is called hemp. Hemp is basically a cannabis plant that has very, very low THC, negligible THC. So hemp is defined as a plant, a cannabis plant, that has less than 0.3% THC by dry weight. Hemp is useful in farming for those things I mentioned earlier, fibers, seeds, and also for CBD, because it has a higher concentration of CBD, low THC. So that's hemp. Cannabis is the main thing. Hemp is one type of cannabis. Indica and sativa are different strains, all right? And marijuana was a term that was introduced probably by the Portuguese to South America in the 1400s, and then was adopted by people living in Mexico, in present-day Mexico. And when, I believe it's Harry Anslinger, in 1930, wanted to demonize cannabis use, he popularized the reference to marijuana as the evil drug that brown people use from south of the border. And so marijuana sounded more like something with a bad connotation, and that became the popular term for the cannabis plant that has higher THC. But you see how it can be confusing. People use different words to describe similar things and vice versa. So we need to know what we're talking about here so we can communicate and learn. Phytocannabinoids are cannabinoid molecules that grow in plants. Those are phytocannabinoids, like THC and CBD, and there's lots more. Synthetic cannabinoids are cannabinoid molecules that look like THC, but are created in the laboratory by companies that want to produce medications like Marinol to help patients with nausea or AIDS patients with wasting. And then endocannabinoids, we heard earlier, are the cannabinoid molecules that we produce in our own bodies. Endo means inside. And you may be familiar with the term endorphins, right? Anybody here have a recent endorphin rush? And no runners? No? No what? No? It's been a while since you had your endorphin rush? So how did we learn about endorphins? We learned about endorphins because opiates from the poppy plants were found to be extremely effective as analgesics, right? Morphine, opium, heroin, those are opiates from the poppy plant. That led to the discovery of receptors in our bodies that bound those plant molecules, and that's the endorphin system. And of course, we have endogenous morphine-like chemicals. Those are in our bodies. Those are endorphins. So the same thing happened with cannabis. There's a plant. It's useful throughout history. We learned that it binds to receptors in our bodies, the endocannabinoid system. And then we learned that our bodies actually produce molecules that basically God gave us to run the endocannabinoid system. So she was pretty smart about that. Now, you saw in my bio I have 4 daughters. So. Okay, we have 4 daughters, sorry. Here's a list of the popular cannabinoids that are found in the plant, the phytocannabinoids. And just for your information, THC, which is the cannabinoid that makes people high, in the plant comes as an acid that needs to be heated before it becomes activated and biologically active. So that's why you can eat a bunch of cannabis leaves and it really won't affect you too much. But if you cook it in a brownie, of course, you get much more of an effect. However, we know that throughout history, people have been using those cannabis leaves and making different types of teas out of them and using them in all sorts of ways. And we're learning more about this all the time. This is new science, so we're learning more about these molecules. Phytocannabinoids are produced in the plant, usually in the flowering tops of the cannabis plant. That's why we call them buds. They're buds, right? And these female plants that produce buds create a host of molecules that are moist and resinous, as you can see here in this magnified picture. These resin glands contain the phytocannabinoids that we use to make medication. Synthetic cannabinoids, I mentioned, were produced mainly in the, I believe it was the 80s and 90s, and were approved for use in patients with AIDS wasting syndrome and chemotherapy-induced nausea. These synthetic cannabinoids are THC molecules created in the laboratory. There's no other cannabinoids. There's no CBD. There's no THCA. It's just THC. And what happened was, this molecule did not work as well as bud. And all these patients that were being treated for cancer in the 1990s and prescribed Marinol by their oncologist went into the office and told their doctors, hey, you know what? This Marinol's not working for me. I'd rather smoke a joint. And then there was a survey of oncologists in the 90s, and over 70% of oncologists said, we are good with that. Let these patients have their cannabis because this Marinol does not work. We know also now that there's other types of synthetic cannabinoids like K2 and spice. You may have read something about this. These synthetic cannabinoids can cause really serious psychiatric problems, something like a zombie apocalypse. That's the headline. Have you heard about that? Yeah, patients are dying from this. So yeah, synthetic, bad, organic, good. And here's a little cartoon of the endocannabinoid system. And I know this is one of those dense science things I alluded to earlier, but I just wanted to highlight how these molecules in our body that are the endogenous cannabinoids, the 2 main ones are called anandamide and 2-AG. Those 2 molecules, anandamide and 2-AG, are produced on the receiving end of the synaptic transmission. You know, nerves communicate with each other across a space called the synapse. And one nerve sends a molecule of neurotransmitter chemical to the next nerve across the space. That's neurotransmission. That's how nerves talk to each other, by molecular messengers. little chemicals that float across the synapse. They bind to receptors on the postsynaptic membrane, and they tell the next neuron what to do. And that's basically how it all works. So what happens if this first neuron here is overactive? What if the signal it's sending to the second neuron is overzealous? Well, there's a condition called excitotoxicity that results. Excitotoxicity results when there's too much activity and the feedback loop to shut down the first neuron is not working. So excitotoxicity has been implicated in the pathology of ALS, Alzheimer's, and Parkinson's disease. Excitotoxicity is a bad thing. There's a lack of balance. There's a lack of homeostasis, as Alice mentioned. Cannabis, or rather cannabinoids, are endocannabinoids, which are produced here at the bottom. Part of their job is to turn off the first neuron. We know this. We have analyzed these receptors. We've done studies. This is real science, even though it's in a cartoon. What happens if you don't have endocannabinoids? What if you have a deficiency? You have something that some people call endocannabinoid deficiency syndrome. There's other deficiency syndromes in the human body. What if you don't have dopamine, which is one of the neurotransmitters? Parkinson's. If you don't have enough dopamine, you develop Parkinson's disease. What if you don't have enough serotonin? You get depressed or anxious. That's why serotonergic agents like Prozac and Paxil work. That's why dopaminergic agents like Cinnamon or carbidopa work. People have an endogenous deficiency, so what do? We supplement it. Here, patients, I believe, and others believe, certain patients have an endocannabinoid deficiency. And by supplementing that with, yes, phytocannabinoids like marijuana, we can help those patients, and we believe that that's what's going on. Pretty cool, right? So again, just a little bit more depth. When patients come in, we talk about indica sativa, but it's much better to refer to different cannabis strains in a chemical way so that we can be specific about how much THC and how much CBD is in each product. We call that chemobars. Varietal names like Acapulco Gold, 9-Pound Hammer, Charlotte's Web, and so forth. Mayaca Gold. You know, these are fun varietal names, and they have meaning to a lot of people. So that's okay. Different methods of administration. There's 3 main ways that patients can use cannabis therapy. You can inhale it, traditionally as a smoke, but in Florida, smokable cannabis is still not legal. That's coming, right? Some of you may have seen that. But for now, you can inhale cannabis as a vapor. So there are these devices called vape pens for vaporization. You can get some cannabis oil derived from the plant. You heat it in an electric pen, and then you inhale the vapor. There's no tar or hydrocarbon. There's no combustion. There's no fire. It's not hot, really. I mean, it's heated, but it's not like fire hot. And the other ways to inhale cannabis, there's a metered dose inhaler, like an asthma medication. These dispensaries are coming up with amazing ways for people to use cannabis. And the products that they're creating and selling are extremely reliable and highly regulated. So these are not, these are not pot shops where you don't know what you're getting. They are extremely regulated. You can swallow it or put it in your mouth and have it get absorbed inside your mouth. That's intraoral. And there's different advantages to that. When you swallow cannabis, for example, the effect lasts longer. Whereas when you inhale it, it's 3 hours. When you swallow it, it might be 6 or 7 hours. There's advantages and disadvantages to both. I have lots of patients with sleep problems. Some people have trouble falling asleep. Other people have trouble staying asleep. So we have that conversation. And for the folks that have trouble falling asleep, we use vape, because that kicks in right away, gets them to sleep. But if they have trouble staying asleep, we may use oral, we may use a capsule, because they swallow the capsule when they're falling asleep, and then it kicks in while they're asleep and keeps them asleep. So there's a timing thing. And then, there's topical. Topical lotions and creams and patches are available, also patches, cannabis patches. Which is really a nice way to treat someone with dementia, for example, because they don't want to deal with sprays or capsules. So you put a patch on a patient who has cognitive impairment, and it releases a slow amount of cannabis over the next day or two. And that's a very safe and reasonable way to use that therapy in a patient like that. The potency of cannabis is measured by the total milligram weight, the ratio of CBD to THC, because the two molecules work together. That's why Marinol doesn't work, because you need more cannabinoids to work together. That's called the entourage effect. These different molecules help each other out. It's like an entourage. That's Dr. Meshelham's phrase. And first pass effect is what happens when the cannabis is metabolized by the liver. That's why people that eat cannabis, when they go on a drug holiday to Colorado, get sick and end up in the emergency room. Because they don't realize that eating cannabis creates a more potent molecule that lasts longer. And that takes about an hour to kick in. So someone goes on a, I guess it's a tourism would be the proper word. They're a cannabis tourist, right? They go to Colorado, they buy some gummies, they eat a gummy, and nothing happens after an hour. What do? And then 2 hours later, they're down. They're sleeping. They can't wake up. They have to go to the emergency room. So that's part of that is just dumb. Well, I guess it's all just dumb. But a lot of it is pharmacology. The pharmacology is that it takes time to absorb the cannabis. It's metabolized by the liver to a more potent molecule. If anybody wants to learn more about this, and I don't get to it, please go to our website, neurologyofcannabis.com. I have blogs on there with all sorts of additional information. I have cards and brochures with the contact information also available, so you can continue your education. So, I don't know if I'm going to get to everything. I have to speed up. Are you guys okay? Yeah. It's all right? You're not asleep? No? Not like that sermon? I mean, not like the sermon. No, I didn't see the audience at all in the sermon. Okay, so here comes the hardcore science, okay? Because doctors want to know, patients want to know, where's the research? And as Alice said, there's a paucity of research from the United States because Schedule I drugs are almost impossible to study in the United States. But in other countries, we have research. So there is scientific evidence. We also make medical decisions, evidence-based medicine, on our own clinical judgment. Physicians that have seen patients respond to cannabis that didn't respond to other medications, for example, for migraine therapy, that goes into the evidence-based medicine calculus. And then, of course, there's patients' values and preferences, which we have to respect. Patients are using products, they're feeling better, we have to respect that. So when it comes to deciding in an evidence-based way what's best for the patient, I think a thoughtful physician takes different things into account. This study from JAMA, Journal of American Medical Association in 2015, looked at 76 or so studies that were scientifically rigorous, which means there were control groups, there was a placebo, it was a very strict scientifically based study, and they found that looking at these studies, cannabis was effective for pain and spasticity. It was also effective for nausea and vomiting due to chemotherapy, sleep disorders, and Tourette's syndrome. The verbiage here is not too exciting. It says that there was low quality evidence, which means that it wasn't quite as rigorous. But this is a very high standard of qualification to make it into this study. And it showed that the cannabis was helpful. There's other studies. I'm sorry, this is also part of the JAMA study, and it shows the side effects in those groups. And you can see here the most common side effects, the individual side effects. I'm sorry, this is impossible for you to read, but I just wanted to point out that there are side effects of cannabis therapy, and we have to treat it like any other medication and be careful and cognizant of that. The most common side effects were dizziness, dry mouth, nausea, fatigue, somnolence, euphoria, depression, vomiting, diarrhea, and so forth. So there is a potential for side effects like any medication, and that's why we always start low and go slow. Here's another study. This study was done in Italy in patients who had chronic migraine. Now, some of you may have had migraine. Probably everybody here has had at least one migraine in their life. But some people have migraines that just won't quit. And those chronic migraine patients, we think, have an endocannabinoid deficiency. How do we know that they have an endocannabinoid deficiency? Well, we have to measure the amount of endocannabinoids. And these endocannabinoids, remember, are floating around between neurons in the brain, and the only way to really measure them is to do a spinal tap. And so, I know, these researchers somehow convinced 35 people to undergo these spinal taps. And what they learned was that the amount of anandamide, which is one of the endocannabinoids, in the patients with migraine was half what it was in the normal patients. So this is de facto evidence of an anandamide deficiency, an endocannabinoid deficiency in patients with chronic migraine compared to normal controls. This is a study from Colorado where patients with migraine were treated with cannabis, and the frequency of their migraines dropped to half. This is a study from Israel showing that in over 900 patients that had different conditions, cancer and so forth, cannabis was useful. For example, in that big group of patients that were all over the age of 65, by the way, cannabis therapy resulted in a significant improvement in pain. So here, this scale here shows that in patients, the intensity of pain before treatment was way high. Whereas after treatment, there was very little pain. This is the pain scale, more intense pain here. This is before treatment. After treatment, very few people had intense pain. The light blue bar here shows that after treatment, the majority of patients had zero pain. It's a little difficult to see, but I think you get it. The same study in the 965-year-old patients showed that on quality of life measures, after treatment, the majority had a good quality of life. Whereas before treatment, the dark bars, before treatment, the majority of patients had a bad or very bad quality of life. And finally, this is the patient's perception of whether or not the cannabis therapy helped them. And you can see that the vast majority thought that cannabis overall gave them a significant improvement. This is a 6-month study in 900 patients in Israel, all over the age of 65 with all those different conditions. These were the adverse events reported by those patients. And in order to earn a spot on this table, you had to have one of these things at least once during that 6 months. So if you complained of dizziness or dry mouth or somnolence or weakness, you earned a spot on this adverse event table. And so these are similar to what we saw in that JAMA study. These are the main side effects of cannabis therapy. And remember, this is in patients with cancer and other serious illnesses, which may or may not have these side effects may or may not be due to the cannabis necessarily, but nonetheless, these things do happen in some patients with cannabis therapy, so we have to be careful about that. Here's a study on fibromyalgia, which I also believe, based on the work of Dr. Ethan Russo, who put forward this theory of endocannabinoid deficiency. He says that patients with chronic migraine, fibromyalgia, and also irritable bowel syndrome are probably suffering with endocannabinoid deficiency syndrome. These are all conditions that we don't really understand with our modern medicine and our standard therapies. Our standard therapies don't help those patients. So that's why patients with fibromyalgia are so frustrated, because the doctors don't know what's wrong with them. So they say, okay, well, you're depressed, you're anxious. And maybe it's not that. Maybe it's endocannabinoid deficiency syndrome. Because in this study, patients with fibromyalgia, this is 1,300 patients answered this survey. Patients with fibromyalgia were treated with a variety of medications. Duloxetine, which is an anti-anxiety medication. This is an antidepressant medication that's popular in Europe. Pregabalin is Lyrica. Some of you may have heard of Lyrica. And here's Cannabis. And the scale shows that the green bar here, which represents very effective therapy, the very effective therapy is not duloxetine or milnacipran or pregabalin. The very effective therapy in their mind was cannabis. So you can see that patients with fibromyalgia found on their own that cannabis was better than Lyrica and other treatments. Maybe they have a deficiency of anandamide and would like to come in for a lumbar puncture. No, they don't. So I'm going to summarize. Basically, we are learning now more about what human civilization has known for over 5,000 years. This is a remarkable plant. It's got all sorts of benefits in terms of agricultural use, but also as a medication and as a spiritual aid, and it's relatively safe. It's time for us to continue with our research and provide this treatment in a careful and responsible way to patients who need it. Aspirin, after all, was originally derived from bark of the willow tree, right? And aspirin, we know, has been helpful for so many things. It also has side effects, right? Bleeding, ringing in the ears, allergies. That doesn't mean we don't use aspirin. It comes from bark. Cannabis is like aspirin on steroids. I'm kind of mixing my metaphor. But the point I'm making is that cannabis is relatively safe. I think if we use it in a responsible way, we can make a lot of people well. Thank you very much.